The assessment of electrolyte status is extremely important because timely identification and appropriate management can result in significant improvement in outcome in most conditions, because most situations of electrolyte abnormalities are readily amenable to treatment in early stage. Delay in diagnosis and management may be lethal in certain situations. Serum sodium is an extremely important tool to assess, and it can be done any time of the day. The major caution should be that it should be avoided immediately after strenuous exercise and seizures, because there could be transiently high levels of sodium which may fall within 15 minutes of these episodes. Values may be false, particularly hyponatremia is observed in the setting of increased protein, lipid or hyperglycemia. However, use of ion selective electrodes is associated with normal sodium levels in the setting of hyperproteinemia or dyslipidemia. Hyperglycemia still will result in coming out of water from the cells, causing dilution, and for every 100 milligram per dl or 5.5 millimoles per liter increase in blood glucose, we need to correct the sodium levels by 1.6 millimoles per liter. High or pseudohyponatremia may be described in the setting of hypoalbuminemia. Under most situations, the normal range is 135 to 145, which is static across the age. Hyponatremia, however, is typically defined because significant symptoms happen only when the levels are less than 130, and hyponatremic symptoms happen once they are more than 150. Pseudohyponatremia typically happens in the setting where there is increased solid phase, and therefore there is falsely low levels of sodium once the actual levels are normal. This typically happens in the setting of lipids. While for glucose there is a drag which basically gets the water out, and therefore there may be a true component which needs to be corrected. For every 100 milligram per dl or 5.5 millimoles per liter rise of blood glucose over the normal, one needs to add 1.6 millimoles to the sodium levels. Use of ion selective electrode typically obviates the problem of protein associated hypo or hypernatremia which is there. A very important cause of sodium abnormalities is the urinary abnormalities as far as the sodium excretion, and therefore urinary sodium excretion is very important to assess in any child who has hypo or hypernatremia. This can be measured using a spot urine sodium, which is a reasonably reliable form because there is a huge discrepancy between the various causes of hypo or hypernatremia. However, fractional excretion of sodium can be used in certain situations and can be helpful, but it is calculated by the ratio of urinary to serum sodium divided by the ratio of urinary creatinine to plasma creatinine, and basically corrects for the abnormalities as far as the renal correction or the renal function is concerned. In the setting of hypernatremia, if the urinary sodium is low, it means that there is an extra renal cause, while if the urinary sodium is high, it indicates salt load. In hyponatremia, if the urinary sodium is inappropriately high, so there is a concentrated urine in a setting of a dilute blood, it means either salt loss or SIADH, while a low urinary sodium is normal and typically means an extra renal cause like diarrhea. Assessment of osmolality is also important in certain situations of sodium and potassium disorders, and this can be done using a measured osmolality or a calculated osmolality, wherein we use 2 into sodium plus glucose upon 18 if it is used as milligram per dl, or plain glucose millimoles along with 1. These are the 3 major determinants of osmolality. Plasma osmolality levels less than 270 are confirmatory of hyponatremia. In this situation, one would expect the urinary osmolality to be low. But if there is urinary osmolality which is more than 100, there is a possibility that there is abnormalities as far as SIADH or a salt loss is concerned. While if we have appropriately dilute blood and dilute urine, it indicates fluid load. Plasma osmolality more than 300 is sufficient to trigger maximum urinary concentration, and one would expect urinary osmolality to be more than 600 milliosmoles per kg in this setting. But if the urinary osmolality is less than 600, is indicative of diabetes insipidus. A very important test in the setting of hyponatremia is the vasopressin test, which is done in the setting of a concentrated blood and a dilute urine, which is indicative of diabetes insipidus. So when the serum sodium is more than 145 or the plasma osmolality is more than 300 and urinary osmolality is less than 600, it is diagnostic of diabetes insipidus. And in this situation, one can give aqueous vasopressin at the dose of 0.1 unit per kilogram and assess urinary osmolality at 2 and 4 hours. If there is increase in urinary osmolality of more than 50%, it is indicative of central diabetes insipidus, while if the increase is less than 50%, it is nephrogenic diabetes insipidus. The assessment of renin, angiotensin, aldosterone system is particularly important in the setting of hypo and hyperkalemia, and the options which are there are to assess are the plasma renin activity, which is the amount of angiotensin 2 produced every hour after addition of plasma, or the plasma renin content in which the substrate limitation is taken care of. Plasma renin content is a more reliable although less available marker of renin activity, and these two are very important to assess in various situations. One can also use aldosterone level and the aldosterone to renin ratio, which can be used in these situations. In the setting of salt wasting situation, low renin is indicative of hyporeninism, while high levels should prompt evaluation for aldosterone, which if low is suggestive of aldosterone deficiency, while high are indicative of pseudo-hypoaldosteronism. In hypokalemic alkalosis, high renin suggests hyperrenism, typically in the setting of renal artery stenosis, while low renin should be evaluated using aldosterone levels, which if high are associated with true excess, while low indicates apparent mineralocorticoid excess, which should further be evaluated by the measurement of deoxycorticosterone level to evaluate for possibilities of ectopic ACTH or Cushing syndrome or CAH variants. Serum potassium levels can be done at any time of the day, but one needs to be cautious because it is predominantly an intracellular ion, and any amount of hemolysis or the use of syringe increases the likelihood of increasing potassium levels. No tourniquet should be used, and the sample should not be allowed to stand for a long time because could be alteration, particularly if the WBC or the RBC counts are high. Pseudo levels of hyperkalemia may happen in the setting of hemolysis, while low levels can happen if it has been stored with high count for a long time. One should also remember that blood gas analyzer typically gives a reading which is lower by around 0.4 millimoles per liter, and the levels as discussed are affected by tourniquet, squeeze sample and high blood count. We need to understand that the potassium levels are variable with regards to different ages because they are largely dependent upon renal functions. So while the levels are higher in the preterm neonates, hyperkalemia is defined only when the levels are more than 7. The levels tend to come down in term neonates, but only after infancy do we tend to use the adult levels, and again one needs to be cautious when one is using the blood gas analyzer in this setting. Urinary potassium excretion assessment is particularly important, especially in the setting of hypo or hyperkalemia. The measures that are used to assess that include the spot urinary potassium, which is usually sufficient in most cases, or fractional excretion of potassium, which like sodium is assessed with the ratio of urinary to serum potassium divided by the urine to serum creatinine level, and levels more than 2% means that there is significant loss. In the setting of hyperkalemia, one would expect the urinary potassium to be high, and if the urinary potassium is less than 20, it indicates a renin, angiotensin, aldosterone system defect, while in potassium load the levels are extremely high beyond 100. In hypokalemia, again one would expect the urinary potassium levels to be low, but if they are more than 25, it means that there is a renal loss, while levels less than 25 are indicative of extrarenal loss. One test which has been considered a reasonably reliable marker as far as the mineralocorticoid effect in the renal potassium excretion is the trans-tubular potassium gradient. The basic principle for this is that the RAAS system is the major determinant of potassium excretion, and most potassium which is found in the urine is actually derived from the effect of RAAS in the collecting duct. So this transtubular gradient, therefore if the RAAS is more, one would expect the urinary potassium to be more, while if RAAS is defective, the urinary potassium will be less. So this transtubular potassium gradient is a typical ratio of urinary potassium and plasma potassium, and it is corrected using osmolality measures for both to ensure that there is adequacy as far as the urinary collection is concerned. The prerequisite for the use of TTKG for assessment of aldosterone action is that urinary osmolality should be more than 300 and urinary sodium should be more than 25 to ensure that there is enough sodium to actually allow for exchange. In the setting of hyperkalemia, a transtubular potassium gradient of less than 6 is considered to be a reflector of RAAS defect. However, now a direct urinary spot has also been found to be reasonably effective and TTKG may not be required in most situations. As discussed, most situations of hypokalemia are associated with metabolic alkalosis. Hypokalemia with acidosis, however, is a rare situation and should prompt the possibility of renal tubular acidosis, and wherein anion gap becomes extremely important. In simple terms, anion gap is the difference between unmeasured anion or the unmeasured negative ions and unmeasured positive ion. In our clinical terms, this is the difference between the measured positive ion, this is sodium, and measured negative ions, chloride and bicarbonate. Under normal situations, it's 10 to 12 millimoles per liter. Accumulation of organic acids like lactate, ketone and organic acids causes the increase in unmeasured anion, therefore causes increased anion gap. While loss of bicarbonate or increase in hydrogen chloride levels in the setting of RTA and diarrhea causes decrease in bicarbonate, which is compensated by increase in chloride level. So in this situation, the anion gap remains normal. Therefore, a normal anion gap in the setting of metabolic acidosis is suggestive of either renal tubular acidosis or gastrointestinal loss. A very important differential of acidosis with hypokalemia is whether it is because of diarrhea or renal tubular acidosis, and in this assessment, the urinary anion gap is importantly identified, which again is a difference between unmeasured urinary anions and unmeasured urinary cations. In clinical terms, there is a difference between the measured positive ions, which is sodium and potassium, and chloride. So it's urine, sodium plus potassium minus chloride, and it is a very important marker of ammonium production. So in normal situation like diarrhea, when there is metabolic acidosis, ammonium production is increased. Therefore, the unmeasured positive ion is increased, resulting in a negative anion gap. While in the setting of renal tubular acidosis, there is impaired ammonium production, resulting in decreased unmeasured anion and a positive anion gap. So in a child with hypokalemia and acidosis, a positive anion gap in the urine is suggestive of renal tubular acidosis, while a negative urinary anion gap is suggestive of diarrhea.